Hello, my name is Dr. Janet Mahoney. I'm CEO and founder of Arete Rehabilitation. Thank you for joining me today. We're going to be learning about the new MDS section, Section GG. As you know, it is slated to go into effect on October 1st, 2016. It does vary from other MDS sections in a few important ways that we will examine during this presentation. The IMPACT Act of 2014 required standardization across the care continuum. This meant that CMS needed to standardize patient assessments and quality measures to allow post-acute providers to exchange information and coordinate care between settings. So skilled nursing facilities must submit functional measures that are detailed in Section GG as part of this initiative. This section must be completed twice during a Medicare beneficiary's Part A stay, at admission, and then again at discharge. This is where the assessment varies from the rules of the previous portions of the MDS, because the assessment period is 3 days. For the admission assessment, the assessment must be completed within days 1 to 3 of the PPS stay, and for discharge, the assessment must be completed as close as possible to the discharge date, but could be completed anywhere from the 3rd, 2nd, or 1st day prior to the discharge, up to and including the day after discharge. The RAI manual instructions for this section define 3 important phrases, the first being usual performance. It's defined as a resident's functional status can be impacted by the environment or situations encountered at the facility. Observing the resident's interactions with others in different locations and under different circumstances is important for a comprehensive understanding of the resident's functional status. If the functional status varies, record the resident's usual ability to perform this activity. Do not record the resident's best performance and do not record the resident's worst performance, but rather record the resident's usual performance. It is important to remember not to record the staff's assessment or opinion of the patient's ability to perform a task. You only code the patient's actual ability to complete a task. The second term the RAI manual defines is helper. A helper is defined as the facility staff who are direct employees or contracted employees like rehab services of the facility. It does not include those who are hired, compensated, or not by individuals outside of the facility's management and administration. Examples of these would be hospice staff and students. The third definition is use of assistive devices. Coding the performance of the resident is not influenced by the use of an assistive device, but coding depends on the amount of assistance from the helper the patient requires regardless of whether they're using a device or not. Consideration is the patient's safety or quality of performance. The MDS should be coded to reflect the amount of assist the helper provides to keep the patient safe or to improve the quality of the activity. For example, Mr. Smith transfers frequently at night from his wheelchair to the toilet, but he never remembers to lock his brakes. When the CNA sees him attempting this unsafe transfer, they provide supervision and cues for safety. The MDS is not coded for the patient's transfer level, which technically is independent, but is coded based upon the assist level the staff provides to keep him safe, and in this case, it's supervision. All right, let's start with patient admission. Section GG assessment occurs during days 1 to 3 of the admission. The areas that are assessed are eating, oral hygiene, toileting hygiene, sit to lying down to sitting on the edge of the bed, sit to stand, chair, and bed-to-chair transfers, determination if walking is clinically indicated, walking with 2 turns, walking in a straight line, using a wheelchair with 2 turns, wheeling a wheelchair in a straight line, and a description of the type of wheelchair used. Assessments must be based on direct observation, patient self-reporting, the licensed clinician assessment, family, or other caregivers. As stated, the admission assessment must be completed and based upon the patient's performing during the first 3 days of the Medicare Part A stay. The RAI manual states that the assessment should be completed prior to any therapeutic intervention to attain the most accurate baseline status. The admission assessment also requires both current assessment of a task and a discharge goal to be coded. Licensed clinicians establish the goals at the time of admission through professional judgment, their standards of practice, information obtained for the 5-day PPS assessment, and discussions with the patient and/or family. Goals are based upon all the factors that come into play when evaluating a resident for each individual discipline. It may be necessary to code a discharge goal the same as the admission assessment if the licensed clinician determines that the resident would be able to retain their admission functional status. For example, a patient who requires assist with wheelchair turns upon admission and also required assist with wheelchair turns at home prior to admission, they would be coded the same for their admission, performance, and their discharge goal, because it's reasonable to expect that the patient would retain that performance throughout their stay and be discharged at the same level as they were admitted. The most important takeaway here is that maintaining a functional level from admission to discharge based upon the clinician's judgment and expertise is acceptable, and thus maintaining that skill is a justifiable and achievable goal. Examine each section. First, self-care. Eating. Eating is defined as the ability to use suitable utensils to bring food to the mouth and swallow the food once the meal is presented on a table or tray, and it includes modified food consistency. Oral hygiene is the ability to use suitable items to clean the teeth. This includes dentures, and it's the ability to remove and replace them from and to the mouth and manage equipment for soaking and rinsing. Toileting hygiene is the ability to maintain perineal hygiene, adjust clothes before and after using the toilet, commode, bedpan, or urinal, and if managing an ostomy, includes wiping the opening but not managing the equipment. Now let's examine mobility. Bed and transfers. Sit to lying is defined as the ability to move from sitting on the side of the bed to lying flat on the bed. Lying to sitting on the side of the bed is defined as the ability to safely move from lying on the back to sitting on the side of the bed with the feet flat on the floor. Transfers include the sit to stand, which is the ability to safely come to a standing position from sitting in a chair on the side of the bed. Chair to bed transfers, the ability to transfer to and from a bed to a chair or wheelchair. And toilet transfers, which is the ability to safely get on and off the commode. Mobility, walking or wheeling. A question of whether or not the resident walks is asked. It's answered either yes or no and includes whether or not it's clinically indicated. Is a patient able to walk 50 feet with 2 turns? This is defined as once standing, the ability to walk at least 50 feet and make 2 turns. Turns may be in the same direction or in different direction, but need to be 90-degree turns. Walk 150 feet. Once standing, is the patient able to walk at least 150 feet in a corridor or a similar space? Does the resident use a wheelchair? This is answered yes or no. Are they able to wheel 50 feet with 2 turns? And again, the turns can be the same direction or different direction, but must be 90-degree turns. Is the type of wheelchair or scooter used manual or motorized? And are they able to wheel 150 feet once seated in a corridor or similar space? Now let's look at the assist levels. First, dependent. This is where the helper does it all. The patient can't help, not even a little bit. Anytime 2 people are involved in assisting a patient, it does need to be coded as dependent. For example, a patient with a stroke with the inability to feed themselves because of a paralyzed upper extremity may need to be fed by a helper. Or a patient with dementia who is unable to follow the steps to brush their teeth may require the staff to brush their teeth. A morbidly obese patient may require 2 helpers, one to steady the patient and one to manipulate their clothing when they're attempting to use the bathroom. Or a patient with multiple lower extremity wounds may require 100% of assist from a helper to get from lying down to the edge of the bed. Substantial or maximal assist. This is where the helper provides more than 50% of the effort to complete the task. For example, a patient with a hip fracture may need help moving the affected leg to the edge of the bed and then may require assistance lifting the upper torso. Since this patient is able to move their unaffected leg and use their arms to help, they're coded at substantial or maximum assist. Another example is a patient with Parkinson's who needs a helper to gather their toothbrush and toothpaste, place the toothpaste on the toothbrush, and then guide their hand to their mouth and assist with the brushing motion. Another example is a patient might be able to propel their wheelchair in the hallway for about 10 feet, but gets so fatigued is unable to push any further and requires a helper to get the rest of the distance to the main dining room. The next level of assist is partial or moderate assist. This is where the helper provides less than half the assistance. For example, a patient who has urinary urgency may be able to get into the bathroom on her own, but needs a helper to lift her Johnny and pull down her undergarments so she isn't incontinent. Another example is a patient with back pain may need a helper to bring the walker to the edge of the bed and help lift the patient to standing. Now the patient does help a little bit, but the effort is equally split. Another example is a patient with COPD who's able to eat most of their meal, but fatigues quickly and needs a helper to finish feeding them the last portion of the meal. The next level of assist is supervision or touching assist. A helper provides supervision, cues, touching or steadying intermittently or throughout the task. For example, a patient with dementia may be able to get into the bathroom and gather their oral hygiene items, but requires step-by-step cues to complete the task. Another patient may be using a cane and is able to walk 50 feet, but when they turn a corner, they get wobbly and need steadying assistance from a helper. A final example is a patient using a motorized wheelchair may need supervision when driving down a crowded hallway to avoid running over the other patients. This level of assist is setup, or cleanup. A patient who may need their food cut up or containers opened is an example of a patient who needs setup. A patient who needs a wheelchair positioned properly to perform a transfer from the bed to the chair is also considered setup. Anytime a helper must place items near a patient to allow task completion is considered setup. Cleanup obviously is reverse, where anytime a helper is required to go in and clean up after a patient, they would qualify to be coded as setup or cleanup assist. Independent. This is where the resident does not require any help at all and are able to perform all tasks soup to nuts. They're able to get up, get out of bed, walk to the bathroom, use the toilet, wash their hands, brush their teeth, walk without assistance, even with an assistive device, eat their meal, or need any help from any staff person. 3 are refused, where the patient has refused, not applicable, which is based upon the patient's never performing this activity prior to the current illness or injury, or not attempted because the patient's medical condition or safety concerns prevent the task from being attempted. The takeaway here is that it's all based upon the patient. Ta-da! You're done. The patient's functional status is assessed as close to the discharge as possible, and it ascertains, again, their best usual performance level. The discharge assessment is required to be completed when the Medicare Part A stay ends. This means on the last skill day if they are converting to long-term care, on one of the 3 last calendar days of the Medicare Part A stay, or day 1 after the discharge. It's based upon the patient's performance as close to the time of discharge as possible. The new section GG will take planning and teamwork, but with both, facilities can expect success. Thank you for joining me in this webinar. Arete Rehab offers full-service post-acute rehab. We are the rehab experts. We are distinctively different.